So, this is important. Why? Because people of all ages and ethnicities can develop anemia at some point in their life. Most of the anemias that you see are very common, and other times they are rare. And they can affect the overall health, can lead to issues where they mostly can be affecting your functionality. It can affect your growth. It can affect, pretty much, your performance. So I think even though you might not have physical symptoms, and it's important that you should diagnose anemia. And obviously in some conditions, anemia can be severe enough and can be life-threatening, and can lead to conditions where you can have congestive heart failure, something like that, where your heart is not able to function in full capacity. So worldwide, what are the causes that you can see that anemia can lead to is, loss of productivity, functionality. There can be poor growth in children. There can be premature deaths, developmental delay. There can be perinatal complications if the mother is anemic, and it can also affect the child, and also susceptibility to infection. Why is this important? Because I think if you screen for anemia in a timely fashion with appropriate basic diagnostic testing, you can catch a patient who is anemic and treat it and prevent these consequences. So this is a chart representing, it's taken from the World Health Organization, showing the population groups that are affected, what's the prevalence of anemia in those population groups. So basically, you will see most commonly preschool age children and, pregnant women are most commonly the groups that get, that you. So these patients basically are the ones who are more vulnerable, especially when you, in the preschool age children, you will see it commonly because of their dietary habits as they're transitioning to regular food, and in pregnant women due to the hemodynamic changes that they're facing, because now they have, a baby in the uterus with all the fluid changes can also result in anemia, plus the addition of the dietary changes that they are also seeing. This is the map showing typically which are the areas that are prone to severe anemia, and obviously one would be nutrition, but commonly there are certain kind of hemoglobinopathies that are commonly seen in South America, in African countries, as well as India. So we know when we talk about anemia, we start with the red blood cells. Red blood cells are the cells that are really taking the oxygen from the lungs to all parts of the body. So what is the red blood cell typically made up of? What is it important? What are the important proteins in there? So the first main important protein that we talk about is hemoglobin. It is a protein that reversibly binds to oxygen in the lungs, and it transports the oxygen to the tissues. Its characteristic, it's a tetramer, which has 4 globin chains, and obviously the iron is bound to it. Iron is the key element in the production of hemoglobin, and if it is absorbed poorly, then obviously you can develop iron deficiency anemia, and you can. That's why it is very essential that you have high content in your diet for iron. Transferrin is also a protein that transports iron, and ferritin is bound to iron, and it is basically intracellular protein that measures the iron stores in your bone marrow. So this is the structure showing the hemoglobin. Hemoglobin has 2 beta chains and 2 alpha chains, and then the iron is bound to the heme group in these molecules. So basically this is a tetramer, the protein. And when you see, this is the image on the bottom is really kind of depicting, it's very, it's very subtle, but you'll see that this is an oxygenated hemoglobin and this is a deoxygenated hemoglobin. When you look carefully, it's in relation to the iron that is bound to the heme group. When you see it deactivated, the distance between the beta globins would actually increase, thereby showing you a typical image of a deoxyprotein versus an oxyprotein. So when the hemoglobin is being is carrying the oxygen from the lungs to the tissues, it is releasing the oxygen, and then it picks up the carbon dioxide and brings it back to the lungs. So the part 2 is really talking about the definition of anemia, which is, I think, in its own very important, how to differentiate patients having anemia based on their age, their sex, and their ethnicity. So it's very important to always refer back to that. Anemia refers to reduction in red blood cell mass or blood hemoglobin concentration. The limit for differentiating anemia from normal states is always set at 2 standard deviations below the mean for the normal population. So always refer back to see whether this is 2 standard deviations below for diagnosing somebody with anemia. The 2 criteria that we look at, or the 2 lab parameters that we look at, is hematocrit. The hematocrit is the fractional volume of a whole blood sample occupied by RBCs expressed as a percentage. Or hemoglobin. This is a measure of the concentration of RBC pigment hemoglobin in whole blood, which is expressed as grams per 100 ml of the whole blood. So these are the 2 striking, parameters that you look at when somebody is coming in with anemia. This is a chart that I took from the UpToDate, which is a very good overview of what you're looking at when a patient is coming with anemia. How do you see these changes? What are the patient characteristics that affect your hemoglobin concentration, or say who is anemic? So on the top you see the age, the hemoglobin, hematocrit, and the mean corpuscular volume of a patient. So here you can see that if in the age groups, you can see as the age is increasing, you can relatively see increase in the hemoglobin, and we're looking at the 50th percentile here. So and in comparison to the Caucasian and African American age groups, or you could see that typically an African American ethnicity patient will have a slightly lower hemoglobin compared to a Caucasian group. And also, if you obviously look at the male and female, females tend to have slightly lower hemoglobin at the 50th percentile compared to a male. So whenever you're looking at these, it's really important to see the age of the patient and then come to a conclusion whether a patient is anemic or not. So as we discussed in the previous section about the definition of anemia and how it is being, how the sex of a patient or age of a patient or the ethnicity of a patient, can vary in what the hemoglobin levels are. Similarly, if you're having a patient of anemia, you will see patient characteristics that can affect a patient being anemic, and what do you see in certain age groups. So typically, if you're looking at a baby or a newborn, when you look at age, from birth to 3 months of age, you will see commonly what is called physiological anemia. Physiological anemia is typically seen because when the baby is born, you have significant oxygenation, your lungs open up, and there's increased oxygenation to the tissues. And with that, what happens is erythropoiesis is decreased, and the erythropoiesis is decreased because the erythropoietin level suddenly drops. So typically you'll see a physiological anemia, which is the nadir at 6 to 9 weeks of age. That's something that is common, and it kind of, the child recovers from it. Now, if the patient in that age group has a pathological anemia, how do you know that this possibly could be pathological? So if the hemoglobin of a patient in the first month of life is less than 13.5 grams, then you are supposed, you would be, it's a red flag. You would think of why this patient has such a low hemoglobin. If the physiological anemia that you're supposed to see at 6 to 9 weeks of age is less than 9 grams, typically in a patient who has physiological anemia, you would see a hemoglobin level of 11 grams. But if it drops lower than 9 grams at 6 to 9 weeks, then it's it's possible that that's pathological and not physiological. You also have to see the signs of hemolysis. If you see a baby who has jaundice or you see icterus, then again, that's the reason for a pathological anemia and not a physiological anemia. In these age groups, what are the common causes of pathological anemia? You will see it can be due to blood loss. There can be immune hemolytic disease, which could be your ABO-RH incompatibility. There could be congenital infection, which could be congenital toxoplasmosis, cytomegalovirus infections. And it can also be seen in identical twins who can have twin-to-twin transfusion, or you could have a congenital hemolytic anemia that you can see with conditions like called hereditary spherocytosis or glucose 6-phosphate dehydrogenase deficiency. The patient characteristics that that are prevalent in 3 to 6 months of age, the patients who are in that age group, you will typically not see anemia unless there is a pathological cause. So in these groups that are children that are 3 to 6 months of age, there is sickle cell anemia and thalassemia that's usually seen. And as you grow up, if you're seeing anemia, most likely the causes are acquired, and they can be typically iron deficiency anemia. The sex also can hint you towards what kind of anemia some patients can have. Some of the inherited causes of anemia are X-linked, and they occur most commonly in G6PD deficiency and X-linked sideroblastic anemia, which again is a disorder in which the process of making RBCs is affected or erythropoiesis is affected. In girls, in postmenarchal girls, you will see sometimes anemia due to excessive or abnormal menstrual bleeding, and that is also something to look at based on the age of the patient. In ethnicities, you will see these common groups where African American and Hispanic patients will have hemoglobin S and C sickle cell anemia. In Mediterranean or Southeast Asian descent patients, you see commonly thalassemia, and G6PD deficiencies are also commonly seen in these Sephardic Jews, Filipinos, Greeks, and Kurds. So ethnicity of patient can also sometimes give you pointers towards what kind of anemia most likely you're going to see in these patients. So this is a very useful algorithm that you can use when you're thinking of diagnosing a patient with anemia. So this is the algorithm for a patient who to kind of go through patients having anemia. So I'll quickly go over this because I think we already went over the different causes. But this is if you have a patient with anemia that's hemoglobin less than 13.5 grams. We were talking about in a patient born, a newborn in the first month. You then typically look at what is the reticulocyte count. And if the reticulocyte count is decreased, then you think more in terms of anemia of prematurity, anemia after RH incompatibility, which is the blood group incompatibility, Diamond-Blackfan anemia, which it's a rare disorder in which you have bone marrow suppression. You're not able to make all the cell lines, and then drug-induced RBC suppression. Now, the anemia of prematurity, when we talk about that, that's also because when, these premature babies are born, their livers are also immature. So when they have immature livers, the RBC lifespan is shorter, and then you tend to have anemia because of that. So that's anemia of prematurity. If there is an increased reticulocyte count in a patient who has anemia, then you commonly do a test which is called DAT. A DAT test is a direct antiglobulin test which helps you figure out whether this is a blood group incompatibility, and most commonly the ones that you see are RH and ABO incompatibility. The RH incompatibility seems to be more common and severe. This happens when the mom is RH negative and the baby is RH positive. And ABO compatibility, usually you will see in if the mother is O, blood group is O, and the baby's blood group is either A, B, or AB. And that's when you will see, the hemolysis in these patients. If the DAT test is negative, then you start looking at the MCV. If a patient who has anemia, increased reticulocytes, and DAT negative, and has a low MCV, then you're possible in this baby is there could be chronic intrauterine blood loss, which could be due to, again, abruptio placenta, twin-to-twin transfusion, or a fetal-maternal hemorrhage. Or you could see in these kind of thalassemias, which are alpha and gamma thalassemias, where you'll see low MCV. If you have a patient who has anemia, increased reticulocyte count, DAT negative, normal or high MCV, and you see on peripheral smear spherocytes, elliptocytes, stomatocytes, then these are the abnormal hereditary disorders that are congenital from birth. They're called hereditary spherocytosis, elliptocytosis, and then DIC is a condition in which you can have bleeding, which is called disseminated intravascular coagulation. This is common in septic babies. Or you could have a microangiopathic hemolytic anemia or hemoglobinopathies. In all of these, you'll see abnormal peripheral smear. If the peripheral smear looks normal, then you are thinking more in terms of the enzyme defects, if there is hemolysis present. And those are the common ones. The congenital RBC enzyme defects are G6PD deficiency, PK deficiency, and then the infections that you can commonly see are bacterial infections that can lead to sepsis, which can lead to hemolysis. Viral infections, which are congenital, you can see CMV, toxoplasmosis, rubella, HSV, and then fungal infections. So this is a really good overview of going through different lab parameters and trying to really narrow down the possible diagnosis. And this is quite helpful, in coming up with the smaller diagnosis list, which typically with anemia can be pretty broad, differential diagnosis. This part, we're going to talk about the evaluation of a patient with anemia again. And then in this, we will talk about the physical evaluation, the laboratory evaluation, and the clinical symptoms that you typically see in patients. In patients that have anemia, they typically will complain of lethargy. You will see they're typically pale, they're irritable, they have poor oral intake. Irritability is more, in terms of children who have developed some behavior issues as well. Then in changes, like some of these symptoms can also direct you towards what's going on in the body. So if you have a patient who is anemic and has jaundice, and if you find out that there's changes in urine color, then it is more suggestive of hemolysis. If they're bloody stool, hematemesis, they have blood in their, when they're vomiting, they have severe nose bleeding or heavy menstrual bleeding, then you're suggesting anemia due to blood loss, which is an acute loss or iron deficiency. If patients have fevers and cough associated with anemia, they are sick, then it's obviously suggestive of an infectious etiology. Could be viral, could be bacterial. So very important to get a good history, thereby giving you pointers towards what is the possible diagnosis. The history of anemia is also very important in the past to know what kind of possible anemia a patient could have. Prior episodes of anemia typically will tell you that this is likely to be an inherited disorder, not something that they have acquired. Anemia in a previously undocumented normal CBC tells you that this patient has acquired anemia, something that has developed recently. And then, as we discussed in the flowchart, if there is hyperbilirubinemia in newborn babies, then there's a hemolytic etiology commonly seen with, ABO incompatibility or RH incompatibility. And if you see microcytosis at birth, then if this is something that they were told during birth time, that we saw the peripheral smear and your child had microcytosis, then there's a suggestion that this could be some intrauterine blood loss that the baby is continuing, is affected by, or there is a thalassemia that the patient has. So we will have to evaluate for that. Underlying medical conditions can also show up as anemia as being their first symptom, and that could be either you're having a renal disease, a malignancy, or an autoimmune disorder. So any of these could just present with anemia initially, and obviously the symptoms of lethargy, pallor, irritability. So, there are other underlying medical conditions that can be associated with anemia. Here we're talking about, obviously history of whether a patient is taking any drug or has been exposed to any toxin. Especially in children, when we are taking this history, we want to make sure we find out if there's any exposure to paint or home renovations or glazed ceramics, because these are the ones that end up having the lead toxicity. These are, so that's why in US it's very common to get a lead level. It's mandatory to do it. And so that's something that is easily preventable, and lead toxicity can be pretty harmful, in which it can affect the cognition of a child. Anemia following exposure to oxygen drugs, you will in the following slides you'll see the drugs that I'm talking about, or fava beans. This is something again suggestive of patients who have glucose 6 phosphate dehydrogenase deficiency, which is called the G6PD deficiency. These patients are very sensitive to oxygen drugs and can have hemolysis, so therefore that would lead to anemia. Family history, again, family history, if you don't know anything about the patient, but they say, I have a parent who had jaundice or gallstones or big spleen, then again, that kind of is telling you that there must be inherited hemolytic anemia, like something like hereditary spherocytosis, which is an autosomal dominant disorder or inherited disorder. So, if you hear that, you'll be like, okay, there's a possibility of somebody, this patient having hereditary spherocytosis was never diagnosed. Dietary history, it becomes important in terms of children and pregnant women, depending on, because they're more prone to iron deficiency anemia. And this can commonly happen because of, use of low iron formula or not enough formula, introduction of unmodified cow's milk at less than, if you introduce that at the age of less than 1 year, that can also cause iron deficiency anemia. Excessive milk intake can also cause iron deficiency anemia, because you're not allowing the absorption, and that could be, you do not typically want children to be taking more than 24 ounces of milk. Or poor intake of iron-rich foods, which again, it can be commonly seen in preschool children or pregnant women. And so having a good dietary history also is very helpful, because you can eliminate anemia by just figuring out if the iron intake of a child or a patient is low. Travel history, if you're traveling to or from to areas of endemic infection, which are like malaria or tuberculosis, because commonly in these infections, there's a lot of inflammation, and then once you have that much of inflammation, you develop anemia. If you treat the underlying condition, the anemia will automatically correct. The developmental history is also important in children, and that's they will kind of give you also pointers towards what kind of anemia they can have. Development delay is associated with iron deficiency anemia and vitamin B12 deficiency. If you have severe vitamin B12 deficiency, you could also have patients who could have seizures and neurological symptoms like numbness in the extremities. And so very important to ask this question and see. And the development delay in iron deficiency anemia typically is reversible in vitamin B12 too. So it's important to really find out if that's the cause. the deficiency of folic acid, and sometimes you can also see Fanconi's anemia. These patients in Fanconi's anemia, the reason it's mentioned here is because you can have typical facies with Fanconi's anemia. These patients with Fanconi's anemia are kind of delayed cognitively. So again, if a child has physical facies, which we'll be talking about in the next slide, but if somebody has like microcephaly, which means your head is small, head circumference is small, or you have cataracts, or at birth you have, micrognathia, which means your jaw is small. These are associated with Fanconi anemia, and the patient is anemic and they have bone marrow suppression. So that's another way of finding out that this possibly is something that we need to check if this patient has. So we talked about the glucose 6-phosphate dehydrogenase deficiency, which is can be, we have to know what are the drugs that these are just some drugs and some chemical toxins. There's a list of drugs and toxins that you can find, but this is in moderate to severe G6PD deficiency. Usually if you have mild G6PD deficiency, you're kind of okay with any of these exposures to these medications and chemical toxins. But let's say if you have a moderate to severe deficiency, you have to be very careful when you're using these drugs, specifically dapsone, methylene blue, nitrofurantoin, which is commonly used for cystitis or UTIs. This is called, the phenazopyridine, which is the usually typically used in patients who are having urinary symptoms or burning sensation. This is called the pyridium, so in US. So this is something that can also be it's a very harmless drug, but if it's given to a G6PD deficient patient, severe deficiency, they can have severe hemolysis. Primaquine and rasburicase and pegloticase, these are the drugs typically that are you can cause significant hemolysis. The chemical toxins that we are talking about is fava beans, the henna compounds that are naturally found in the plants, naphthalene mothballs that typically are used sometimes in developing countries, the phenylhydrazine, and these drugs like Rush, which are the nitrates, can cause significant hemolysis. So it's very important to diagnose or know a patient of severe G6PD deficiency, and it should be all over flagged on the patient's chart so that they don't get exposed to a drug that can actually cause significant hemolysis. So what are the so we talked about the symptoms that were there. What are the physical exam clues that you are looking for? Sometimes can give you the diagnosis, So like we talked about Fanconi's anemia, in these patients, you will have developmental delay and there can be hyperpigmentations. These are the patients who can have, again, Caffi-Loewe spots, which are hyperpigmentation, multiple spots, microcephaly, micrognathia, cataracts at birth. So, you need to think of Fanconi anemia. If a patient who has, is developing petechia or purpura, then you have to think petechia being these red spots, on all over the body. Then you think of autoimmune hemolytic anemia with decreased platelets, because not only will it affect your red blood cells, but also will affect your platelets. Thereby, you would see petechia, the hemolytic uremic syndrome, which is also common in patients. You will see who have petechia all over their lower extremities, typically, and they will have increase BUN creatinine, and then these patients can develop anemia, hemolysis, significant hemolysis, as low as hemoglobin of 5 in children sometimes. Bone marrow aplasia and bone marrow infiltration. So in these conditions, why you will have petechia and purpura is basically your platelets are lower, and that's why you have associated also anemia, because in bone marrow aplasia is that your bone marrow has stopped functioning and is not making any of the cell lines, which is the white blood cells, red blood cells, and platelets. And bone marrow infiltration is typically seen in patients who would have typically anemia, leukemia, and then they can infiltrate the bone marrow. The carotenemia is commonly something that is when you see patients with yellowish pigmentation of their skin, And these patients are very pale and usually typically seen in iron deficiency in infants, in children. The jaundice is associated, as we have discussed previously, in hemolytic anemia, hepatitis, and aplastic anemia. Cavernous hemangioma is a huge hemangioma. So basically, these are the patients, then commonly again seen in children. And these are big hemangiomas in which the blood can get sequestered and they can develop DIC, and typically they can also have hemolytic anemia. And ulcers on lower extremities in some patients are due to sickle cell disease because their blood vessels are getting clogged with sickle cell disease and thalassemia. These are the patients you'll see decreased blood flow in the lower extremities. They're not able to pump the blood well in their lower extremities, which can lead to stasis, venous stasis, and that can cause skin changes in the legs and also in lower extremities, and also then go on to progress to have ulcers or wounds that typically are hard to heal. The physical exam clues that you can see on the faces is frontal bossing, prominence of the maxillary and malar bones, and these are again seen in thalassemia, patients with congenital hemolytic anemias, and severe iron deficiency anemia. Eyes, you could see microcornea in Fanconi's anemia. You could see typically microaneurysms and tortuosities of the blood vessels in the conjunctiva or retina, again pointing towards sickle cell disease. Cataracts are common in galactosemia and glucose 6-phosphate dehydrogenase deficiency. And retinal hemorrhages can be seen again in severe anemia. Edema of the eyelids is seen in mostly patients who have exudative enteropathy. They're losing a lot of protein, and since they're losing a lot of protein, they tend to become anemic because it is affecting their erythropoiesis and carrying of iron in the body. The other ones that are commonly seen in children is obviously glossitis and angular stomatitis, which is due to, again, iron and vitamin B12 deficiency. There are some characteristics in the chest, which is, again, this is a very rare disorder, but if you do see it, it's something that is, typically a red flag, and you'll be able to make the diagnosis right away. If there's unilateral abscess of the pectoral muscles, this is more in terms of, questions that you can get on your boards, basically. So Poland syndrome, they're at high risk of leukemia. You could develop a shield chest, which, is seen mostly in Diamond-Blackfan syndrome. A typically common question they always ask in med school exams or even in our hematology boards is triphalangeal thumbs is usually associated with red cell aplasia. This is a disorder in which you basically do not make red cells, and this is usually a typical sign for red cell aplasia. Hypoplasia of a thenar eminence is also seen in Fanconi's anemia, and spoon nails, which is commonly seen in iron deficiency anemia. If you have enlargement of spleen, again, that is also, very important in patients to diagnose with congenital hemolytic anemia and hereditary spherocytosis, in thalassemias, in leukemia, lymphoma, in acute infection typically seen in EBV, Epstein-Barr virus infection. You will see in splenomegaly, and portal hypertension typically seen more commonly in adults, in patients who are having liver diseases. That's where you will see spleen enlargement. So we've talked about the evaluation based on history and physical exam. Now we're going to talk about the laboratory evaluation that is also essential. What are the things that we're looking at when we're talking about laboratory evaluation? So there's this complete blood count, which tells you the amount of hemoglobin, the number, size, and shape of red blood cells, the number of white blood cells and platelets, and this can be done with or without automated differential, which will typically tell you the type of white blood cells that are there, what is the percentage of the neutrophil, eosinophils, monocytes, and lymphocytes. It's really typically based on your evaluation on the history and what you're thinking of as you've gone through history and physical exam, how you've narrowed down your diagnosis. If you would prefer to get a manual differential and look at the peripheral smear, it can be very helpful for anemia. I typically prefer having a peripheral smear review, which will kind of give you much more information and narrow down the diagnosis even further before you start sending a slew of tests, to see what's going on with the patient. If obviously you see, crazy abnormalities that are reported in the CBC, then you definitely do have to do a manual review. Something like, let's say, if a patient is showing blasts in the peripheral smear, or a patient has a WBC count typically anywhere from 4 to 16, but now it has 4 to 16,000, and you're now looking at somebody who's having 50,000 white blood cells. So that kind of causes alarm, and you have to do a manual review. Or the platelet count has dropped significantly, and it's from 150,000, it has dropped down to, let's say, below 10,000. So you want to look at the do a manual review of the peripheral smear and see what is going on with that patient. In a complete blood count, just basically what are these parameters? So hemoglobin is described as in grams per deciliter. It's amount of oxygen carrying protein. Hematocrit is described in terms of percentage, percent of blood volume occupied by the RBCs. RBC count is how many million per microliter. MCV is usually in femtoliter. It's the mean cell volume. The mean corpuscle hemoglobin, mean cell hemoglobin concentration is in the picograms. The mean cell hemoglobin concentration, which is grams per deciliter. RDW gives you the red cell distribution width, which is looking at the various stages of the red blood cells in different phases, like all the progenitors. So it looks at the bandwidth. The WBC count is obviously the number of WBCs, and the platelet count is also how many thousands per microliter. Typically, these are the ones that we look at, and these are the units they are described in. So what are you looking at? A little bit of just laboratory information, very minimal. Like when you're looking at hemoglobin concentration, how are they measuring it in the lab? The hemoglobin is measured directly as absorbance of the cyano-meth hemoglobin. And when they're looking at the RBC count, they're actually measuring directly by impedance, which is the flow of the red blood cells while they're running the tests. The hematocrit is measured by centrifugation, the ratio of volume of RBCs to volume of whole blood. You typically can also calculate, if you know the MCV and you know the RBCs, you can get to the hematocrit. The MCV is also measured by mean of height of the voltage pulses in an impedance counter. So if you're using an impedance counter to look at the RBC count, that will also help you to understand what is the MCV, because that will be the mean height of the voltage pulses that they're reading when they're running these tests. And you can also calculate, the MCV using hematocrit and RBC. And the rest of the values are also a calculation that you can do in the laboratories. Roughly, when you know the hemoglobin, you can multiply it with 3, and that kind of gives you, typically that's what we do as, to know what is the roundabout of the MCV of a patient, or hematocrit of a patient actually. So when you're looking at the basic information in these laboratory parameters, you're looking at the size of red blood cells. Are they small, normal, or big? Do you see any abnormal cells on microscopic examination? What do the leukocytes and platelets look like? Are they normal? Reticulocyte count, ability of marrow to respond to anemia. So sometimes when you're looking at the peripheral smear, you can see reticulocytes actually. And if there is increased reticulocytes that you're seeing, that means the marrow is responding to the anemia and seems like the marrow is working. So you really not concerned about the bone marrow as much. And if you see evidence of destructions, so in peripheral smear, you'll see typically change in the shape of the red blood cells. But if you want to see at some of the other laboratory parameters like lactate dehydrogenase, there will be elevated level of LDH, or the bilirubin, which is the indirect bilirubin, which we increased. So let's say if you are looking at a patient who you think has jaundice and has icterus and has an infection of EBV, and you want to see, and you see anemia, then you want to confirm, is there destruction of red blood cells going on? So the other tests that you can order in addition to the CBC with differential is LDH and indirect bilirubin, which will help you nail the diagnosis. So the diagnostic approach that typically you can classify anemia based on the mean corpuscle volume, the mean cell volume. And, this is very helpful to kind of just categorize your diagnosis and figure out what the patient has. So if a patient has, the mean cell volume is less than 80 femtoliter, then you're looking at microcytic anemia. If it is between 80 to 100 femtoliter, it's normocytic anemia. And if it is greater than 100 femtoliter, then it's macrocytic anemia. So basically, you're classifying your anemias into microcytic anemia, normocytic anemia, and macrocytic anemia. What is the differential diagnosis of microcytic anemia? In microcytic anemia, most commonly, the first three things that you'll see is iron deficiency anemia, anemia of chronic disease, thalassemias, and then you could also see hemoglobinopathies, hereditary spherocytosis, hereditary X-linked sideroblastic anemia, which is a very rare condition. In this, you basically there's a mutation in which you're not in the protein that does not allow to have normal erythropoiesis. So these patients can develop anemia based on that, and lead poisoning. Usually you will not see significant microcytosis, but this is under the same umbrella. Iron deficiency anemia is a common nutritional deficiency. Bleeding is a leading cause of iron deficiency anemia. The facts that you need to know is most of the body iron is functional. It's in hemoglobin, myoglobin, cytochromes, and 20% of the iron is in the storage form. It's absorbed primarily in the duodenum. The iron is transported by the protein transferrin, and it's stored intracellularly by ferritin. And when you're looking at hemosiderin, it's usually in the bone marrow, and that's the long-term storage. It's good to know these because when you're looking for iron deficiency anemia, you can send a set of these tests, which will help you narrow down to iron deficiency anemia. So what are the laboratory indices in iron deficiency anemia? As we talked about, you will see microcytic hypochromic anemia. So decreased MCV, decreased MCH, and a decreased MCHC. So your cell volume, your cell hemoglobin, and cell hemoglobin concentration, all of them will be decreased. And the iron studies that you can send is for looking for low serum iron. There will be low ferritin levels. There will be low saturation of the transferrin protein. And you will see that the transferrin iron binding capacity obviously will be increased because now you have less of iron and you have more free transferrin. So this is something that you look for. Typically, you're not going in to look for the bone marrow storage iron because that's typically you'll see if you do a bone marrow aspirate, and which is not typically something that we do unless it is really required if other cell lines are affected. In thalassemia, what is the pathophysiology? In the hemoglobin, as we discussed earlier, is a tetramer with 2 alpha chains and 2 beta chains. In thalassemia, there's abnormally low production of either alpha chain or beta chains. And the thalassemia is named after the chain that is decreased or absent. If there is a plus sign indicated, then that means there's diminished or decreased production of that protein. If there is a zero associated with it, like a beta plus or a beta zero, then it indicates complete absence of the production of that gene. Now, sometimes, you have the similar picture in the microcytic anemia, and you're looking at that, you say, okay, I have microcytic hypochromic anemia. How do I know if this is a patient with a thalassemia trait or somebody who has iron deficiency anemia? Thalassemia trait is again a patient who is making significant amount of the globin chain, but has a carrier or has a beta plus. How do I know that this patient is not going to? How do I differentiate with an iron deficiency anemia? So there are a few things that you can look at and say, okay, it seems like this is more likely to be iron deficiency or thalassemia trait. The RBC count in a thalassemia trait patient is usually more than 5 million per microliter. The MCV will be usually less than 70 in a thalassemia trait patient, whereas in iron deficiency anemia is more than 70, but somewhere between 70 and 80. The red cell distribution width in iron deficiency anemia is more than 17%, and sometimes which we use commonly as medical students is Menser index, which the MCV, when you divide the MCV by RBC count, if it's less than 13, then it's likely to indicate thalassemia. So these are like some indications that you can get to differentiate between iron deficiency anemia and thalassemia. And these are some of the board questions that you can get when they're asking these questions about iron deficiency anemia. Anemia of chronic disease. This is again mild to moderate anemia. The reasons that you get anemia in chronic disease is because of inflammation. There's production of this protein called the hepcidin, and this causes sequestration of the iron within the cells. So basically, you're not able to store, they're sequestering the iron and you're not able to store it in the body. So thereby causing mild to moderate anemia. You can also see microcytic or normocytic anemia in anemia of chronic disease. And the most common causes of those are due to immune activation are chronic infections. You could have, collagen vascular diseases like rheumatoid arthritis and malignancy. All of these can lead to anemia of chronic disease. So, since we've been talking a lot about the peripheral smear and talking about hypochromic microcytic anemia or what they look like, I thought maybe I should have a few slides kind of showing. So this is a peripheral smear of a normal patient having no anemia. You see, a little bit of central pallor, and the red blood cells look healthy, and they seem like they're in normal shape because they're biconcave. So you can see them to be typically looking good. In hypochromic microcytic anemia, when you're looking at a peripheral smear, what you see is that the central pallor has significantly increased. And you can also see some changes in the shape and size, which is called onychocytosis or poikilocytosis. Both of these, when you see that, then typically you think of hypochromia microcytic. The reason it's microcytic, usually when you compare it to the a white cell, this is a white blood cell. When you look in relation to that, the red blood cells are typically of similar size. When they start, you can see almost half the size. That's why they're microcytic, and they're hypochromic because of the increased central pallor. So this is something that you will look at when you see a peripheral smear, that hypochromic microcytic anemia can look, the red blood cells can look like that. In beta thalassemia, what you can typically see are these target cells, these bullseye target cells. When you have so many of them, then that typically says that there is some breakdown of the cells happening, and target cells are basically happening because there is some membrane to volume, the surface area to volume ratio is increased, and when that happens, they lose the red blood cells lose their biconcave disc look. And when you're looking under the microscope, it's obviously two-dimensional, and so you will see target cells like this. But if you see under electron microscope, target cells are usually called podocytes, and that's because when you're looking under the electron microscope, the target cells will look very, 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 very thin. So typically, obviously, we're not looking at electron microscope structures. So these are described as target cells on peripheral smear, which typically you will see in the lab, and very common in thalassemia. So we talked about microcytic anemia. Now we're coming to macrocytic anemia, and we're discussing mainly the common causes of that. So in a megaloblastic anemia, which is due to typically vitamin B12 and folic acid, that's what we talked about. And in this, the red blood cell size are much bigger. So that's why they're called megaloblast. And they're affecting not only the red blood cells on peripheral smear, even the red blood cell precursors in the bone marrow are bigger. In non-megaloblastic, which is, you will see the same macrocytic anemia is usually in liver diseases, in myelodysplastic syndrome, or increased reticulocyte count when you have hemorrhage. Now, the common anemia due to folate or vitamin B12 deficiency, we have kind of talked about this. So folate and cobalamin required for DNA synthesis. If there is deficiency of folate or B12, it results in megaloblastic anemia because you're not able to replicate your DNA properly. Impaired nuclear development of the DNA and abundant cytoplasm causes a nuclear cytoplasmic disproportion that leads to megaloblasts and then large marrow progenitors. So similar clinical features are present in both. So folate and B12, you'll have similar symptoms, except in B12 deficiency, as I mentioned before, you can have some neurological abnormalities like seizures in severe, or you can have numbness associated with this. So in the laboratory indices that you will see in this folate cobalamin deficiency is macrocytic anemia, relatively low reticulocyte count, hypersegmented neutrophils, mild thrombocytopenia or neutropenia, and megaloplastic changes in the marrow. Like I said, neurological findings can be loss of position sense, ataxia, psychomotor retardation, seizures, and some paresthesias. Again, this is very severe B12 deficiency, but the good thing is if you correct the B12 deficiency, all of these symptoms will actually go away. So macrocytic anemia, in this you're seeing that the red blood cells are somewhat bigger than the white blood cell here. And, basically that's most common in these, that's what you will typically see in a patient with macrocytic anemia. If you're looking at specifically folate, and this is more like a board question, they will give you a patient scenario who has anemia. They may say he has macrocytic anemia, but again, hypersegmented neutrophils is actually a hallmark of folate or B12 deficiency. So these are sometimes given on your board exams again, hypersegmented neutrophils indicating folate or cobalamin deficiency. The differential diagnosis of a normocytic anemia, we've discussed about microcytic and macrocytic. If you have increased your reticulocytes, which kind of indicates there's breakdown of cells, so then that's hemolytic anemia and anemia following hemorrhage. So normocytic anemia, increased reticulocytes, most commonly seen in hemolytic anemia or anemia with hemorrhage. If there is normocytic anemia and decreased reticulocytes, you're looking at anemia of chronic disease, endocrine disorders, renal disease, liver disease, aplastic anemia, and marrow infiltration. And this is commonly seen in the adult population. Marrow infiltration, obviously, you can have it in leukemia, myeloma, myelofibrosis, or metastasis of a tumor. Could be neuroblastoma. So these are the common things that you'll see. In a normocytic anemia, it's really not much that you can look for as far as the smear is concerned. You can basically eliminate that. I don't see macrocytes or I don't see any schistocytes or stuff unless it is hemolytic anemia. But you screen more commonly for liver, endocrine, and renal diseases. You can send iron studies because when you're having these chronic diseases in the liver, endocrine, or kidneys, in kidneys you will have decreased erythropoietin, which could affect your you could develop iron deficiency anemia for it not being transported well. So it does not hurt to look for iron studies. And if if you want to go further in and you want to look at the storage of the iron or any suspicion of leukemia or myelofibrosis or myeloma, typically myelofibrosis, or metastases, then you end up doing bone marrow biopsy, because that obviously will give you a proper smear to look at metastasis or leukemia. Normocytic normochromic anemia is really typically this, very not much different from what you will see in a patient with a normal smear. Only thing is you won't see as many red blood cells. So, these small, with the white arrow that I'm showing is usually these are the platelets. I did not mark it, but this is how, when you look at peripheral smear, you see platelets. And if you see the smear, I'll look at the platelets and I say, you know what, it looks like the patient has normal platelet count, but less of RBCs. So a normocytic normochromic anemia will look like that. A patient who has liver disease, can I say from the peripheral smear that this potentially could be liver disease? There are some patients who can have acanthocytes, and these acanthocytes are here because of, there's a defect in one of the, in the cell membranes. They develop because they're not making the lipid that is needed for the normal formation of cell membrane. So you'll sometimes see these acanthocytes, which are also called Burr cells. And this could, potentially say allude to the fact that somebody has liver disease. This is again another chart, just typically going over what we have already discussed. So this is something you guys can, review on your own. But this is again looking at MCV if a patient has a normal or low, normal or high MCV, and looking at RDW, whether it's normal or high, what are the conditions or diseases that we are looking at. The hemolytic anemia, we have membrane defects that can cause hemolytic anemia. We've gone over these as well. If it is inherited, what are the membrane defects? Globin defects are in sickle cell anemia, and then metabolic defects. And if it's acquired, it's immune-mediated microangiopathic hemolytic anemia associated with infections. And this is, paroxysmal nocturnal hemoglobinuria, which is also, again, a rare condition in which you develop, destructions of red blood cells. It's typically patients like these have, anemia, they have blood clots, and they also have, impaired, they will usually come up with symptoms of having passing dark urine, usually typically in the morning. So patients who have anemia and these symptoms, you typically look for PNH, and there's specific testing for it, but it's a very rare disorder. It's not something that you commonly see. In hereditary spherocytosis, you will see spherocytes. There will be increased RDW, normal to low MCV, usually increased MCHC, as we have discussed before, autosomal dominant inheritance, and usually in these patients, typically there's enlarged spleen. If you remove the spleen, you can reverse the effects of hereditary spherocytosis. And the peripheral blood smear of a hereditary spherocytosis patient will show a lot of the spherocytes that you can see here. There's no central pallor at all. And in a typical peripheral blood smear, you might see some spherocytes, but in this case, you are seeing more than half of them being spherocytes. So typically, that's why it is hereditary spherocytosis. And there is an osmotic fragility test that you can do in order to see. It is a very sensitive test, and you just measure the in vitro lysis of red blood cells in the solution of decreasing osmolality, and that will help you have a, kind of make the diagnosis of hereditary spherocytosis. And G6PD deficiency, it's very important in the initial step of the pentose phosphate pathway, and it's very common, X-linked, and you can see in different ethnicities how prevalent it is. So like I said, it's very important to identify if you have a patient who has G6PD deficiency and put it all over the chart, specifically if it is severe deficiency. In these patients, you can see in the peripheral smear, this is a crystal violet stain, and you will see these what are called the Heinz bodies. And the Heinz bodies are, the aggregates of denatured hemoglobin because of the hemolysis, or I guess when they're exposed to these oxidative, damage to the red blood cells. So this is a denatured hemoglobin aggregate. And this is usually seen on a crystal violet stain, not on a normal peripheral smear. And sometimes you will see these bite cells that are very common. The immune-mediated hemolytic anemia, we talked about this destruction of red blood cells due to acquired antibodies. It could be, we did do a direct Coombs test, which will tell you about if there is Rh incompatibility, or indirect Coombs test that you will see if there are normal red blood cells which are being incubated with patient serum, searching for unbound red cell antibody in the patient serum, typically seen with infections, mycoplasma. So these are the two tests that can help you differentiate that. And then microangiopathic hemolytic anemia. These are again characterized by red blood cell fragments in the peripheral blood smear, which are called the schistocytes. And the differential diagnosis are again these conditions that you can see: TTP, HUS, hemolytic uremic syndrome, disseminated cancer or carcinoma, DIC, malignant hypertension, giant hemangiomas, and sometimes these drugs like mitomycin C. These are the typical schistocytes you can see in microangiopathic hemolytic anemia. So sometimes if you have significant amount of those in peripheral smear, that will help you also assist in your diagnosis. And the overwhelming infections that you can cause, the hemolytic anemia that is common in these infections that you see in developing countries is, like Clostridium sepsis, malaria, Bartonella, trypanosomiasis, mycoplasma infection, and infectious mononucleosis, which is also very common, EBV. And this can cause significant anemia. It can cause hemolysis. EBV is very notorious to present in multiple ways, and I think it's very important to keep that in mind whenever you have a patient with anemia or thrombocytopenia. And these two I've just added to the slides, really not to really review them with you, but basically for your review. These are very good algorithms to follow for diagnosing the patient, approach to the child with anemia and abnormalities of other cell lines, how it can help you narrow down your diagnosis, what are the tests typically you want to send for if you're looking for one of these diagnoses. And in this, you can see, again, the whole isolated anemia. Everything is really in this algorithm. I'm not sure if you can see clearly, but I hope when you print it, you can look at it more carefully. Is that basically the breakdown of the entire talk that we have done and how you categorize based on the physiological or the morphological features of the red blood cells, and how you classify the anemia based on their testing, shape, size, and really narrow down these diagnoses. So this is very helpful in doing that. So just the take-home summary, basically, which is very important, I feel, is, how do you define anemia? It's very important to look at what you're looking for the percentile. Its threshold for defining anemia is a hemoglobin or hematocrit that is less than or equal to the 2.5th percentile for age, sex, and race. So basically 2 standard deviations. Always look at the age, sex, and race. What are the causes of anemia based upon the age of presentation? Key historical factors in the assessment of child with anemia, including the severity or onset of symptoms. So history is very important. Physical exam, if you keep an careful eye for pallor, icterus, hepatosplenomegaly, abnormal facies, then you will pick on a rare disorder. A laboratory evaluation, is very few parameters, but really can help you make the diagnosis as CBC, like the whole with the differential. Look at the reticulocyte count. Always remember to order these in addition to your CBC so that you have more information. Like I said, typically if I see a patient of anemia, I always want to have a peripheral smear exam so that I can kind of narrow down my diagnosis on the first visit. So any questions you guys have, I'm open to questions. And thank you once again for giving me this opportunity.